To the next session, and I will invite Dr. Vipul Chawda to carry over with the proceedings.
Thank you so much, Pratap sir. It was a wonderful keynote lecture by Dr. Nikhil sir. Now let's enter a very interesting session, that is a debate. And to chair this session, I would like to call Dr. Samir Dani sir, an eminent cardiologist from our own city, Ahmedabad, and Dr. Brij Mohan sir, who is a diabetologist from Kanpur. For the first debate, I would like to say Dr. Samir Dani sir to invite the speaker.
He is Associate Professor at UN Mehta Institute of Cardiology and Research Center, and he's also practicing in private. He has a kind of penchant for teaching, and he has taught subject of cardiology at various levels in medical colleges. So I will invite my other co-chair to introduce the other debater.
Okay.
Or should I?
Thank you. Thank you, Dr. Samir. Thank you, Dr. Samir. It's my privilege to invite Dr. Samit Ghoshal. Before that, I'd like to thank Dr. Banshi Sabu for giving me this opportunity to share this very interesting topic. And now I'll move on to Dr. Samit Ghoshal. He's a very renowned endocrinologist practicing in Kolkata. Everybody knows him. He graduated from Calcutta Medical College, PG again in internal medicine, and then he qualified as endocrinologist. He's practicing right now. Over to Dr. Kamal Sharma for his debate on with Dr. Samit Ghoshal, head to head. Over to you, Dr. Kamal.
Hi, good morning, everyone. Thank you for inviting me. Well, this topic is something that I felt was probably not so much of a debate, but then it's a forum like this. I think I would like to draw an analogy to disclose any similarities to the China's claim over Galwan Valley for today's debate is purely coincidental. And I'm sure the audience, which is predominantly of people interested in diabetology, won't make me feel like an Indian ambassador invited to speak for Galwan Valley in Chinese Politburo meeting. So jokes apart, my first reason why you would not call it an endocrine drug is because of the history itself. So if you know, the first molecule, fluorescein, was basically a glycoside which was derived from bark of apple roots. And as you know, apple, of course, had many benefits, and one of them is decreasing risk of diabetes. Now, I hope and I understand that everybody understands that apple is not an endocrine fruit. It belongs to everybody. Reason two, poor nephrologists, we all know how it acts. It acts at the SGLT2 receptors, and that's how through it, by blocking it, and it's actually in the nephron, not even in pancreas and far off even away from liver, but that's where the mechanism of action of this molecule lied. And apart from the various mechanisms that this molecule has, one of which was, of course, HbA1c reduction, there were a lot of other things that it did. And you can see that the mechanism of action primarily dealt around a lot of stuff around tubular glomerular feedback, plasma volumes, uricose-uric actions, negative cardiac balance, or improvement in the epicardial fat. And so it doesn't just fall into one category of falling just into an action which endocrine drug or an anti-diabetic drug would actually purely qualify as. So mechanism remains again elusive, and now of late in 2020, when people were talking about a lot of ketones and its action, there's another paper which just recently talks about that the SGLT2, it's not the ketones, but it's the angiotensin 2 receptors through which it acts. And all we all know angiotensin 2 receptors, which domain do they fall into? So angiotensin receptor 2 to 7, and through its mediation, there are a lot of actions that happen with the synthetic peptides, reduction in blood pressure, independently or irrespective of volume loss. And then, of course, the cardiac actions and the benefits that might be derived out of the SGLT2, which primarily is the advantage that this class of molecule has, again falls into the domain, surely not in diabetology. Reason 3, it's first, where was the first trial presented? The EMPA-REG was published and first presented an AHA meeting, American Heart Association meeting. And this is from the endocrinology advisor side, I'm talking about. So I just wonder who's talking about hijacking what? Look at the other trials, not just this one trial. Look at the Declare to Me published. Where was it published? It was published in American Heart Journal. Declare to Me was published not in any endocrine society or not even an endocrine journal. It was published in American Heart Journal, and that's where the authors were. And look at the reason 4. Who were the authors who researched this molecule? Of course, there were some diabetologists, but the first author was a nephrologist, there was a neurologist, there was a statistician, there were cardiologists. And look at some other papers, Canvas. It was published at the ACC, and people who were talking about it were all fellow of American College of Cardiology. Deepak Bhatt, Anthony Bavary, James Zanuzzi, all of them are FACC, fellow of American College of Cardiology. Reason 5, all that reduces A1C is not diabetology. I'm sure nobody will talk about lifestyle modification as pure diabetology alone. Lifestyle reductions do reduce HbA1c by 1 to 2%. Do you say lifestyle modification is diabetology alone? Of course not. And if that is the case, now we have paper from our organizer, Dr. Bansi Sabu being one of the author, HCQ. HCQ has efficacy like pioglitazone. Why don't you talk about HCQ being a molecule of diabetology and not rheumatology? You don't talk about it because maybe I wonder in COVID era, like nobody will talk about HCQ again because probably it's off-patent drug and a lot of controversies around it, as we have in Lancet and other papers that were published. And if you look at that paper that Dr. Sabu and others published, you can see that its efficacy was similar to pioglitazone, but nobody talks about HCQ being an anti-diabetic drug. Of course they don't. Look at the non-glycemic benefits of this molecule. That's the reason 7. SACRA study, one of the large study. You'll not listen about this lot of forums. Well published long back, 2018. And it talked about its antihypertensive efficacy. Its reductions were in the range of 9 millimeters of systolic as measured by 24-hour BP recordings. These reductions are very much potent and similar to any potent antihypertensive. Now, if the molecule has got antihypertensive actions as well, which are so profound and strong, it surely won't qualify as pure anti-diabetology drug. Look at the weight reductions. Look at the systolic pressure reductions. And this is from another study from Henry R.R. published in the Lancet 2010. What about EMPA-REG's other outcomes? Look at the OSA reduction. You had 52% reduction in OSA. Nobody talks about it. People just talk about CV mortality. This is another reduction of 52%, a log rank analysis as published in the same subgroup analysis with 52% reduction in EMPA-REG in the patients developing obstructive sleep apnea. Now, this is, of course, not a diabetic action or anti-diabetic action for the reason 8. What is the evidence for treatment of heart failure? Look at the DEPA-HF design. You have patients, we all knew that it would reduce heart failure, but what is more important, people talk about it, that prevents worsening of heart failure, prevents cardiovascular death. But look at this subgroup of data, which had a lot of non-diabetic patients. You had non-diabetic subgroup, which actually had evidence more in favor of DAPA as compared to the patients that had diabetes at baseline. So whether you had diabetes or you didn't have diabetes, it favored reduction in heart failure. And in the evidence was probably even more in favor of those who did not have diabetes as compared to those that had diabetes. What about treatment of heart failure? If you look at the spectrum of the patients that were studied in all the 3 major trials, Declare, Canvas, including the EMPA-REG, you can see that most of the patients had cardiovascular disease, CAD, CVD, or PVD. These were not diabetic disease per se. And then DAPA-HF has already shown that it works even in non-diabetics. So all of these group had patients which were predominantly having CV disease. And in top of that, when you treated them with this class of molecule, you did reduce to a huge extent the CV outcomes. So risk factors or CV disease when it existed goes on to tell you that how important it was to change the outcomes in these subgroup of patients. We look at all the 3 outcome studies, the large studies, and you can see that the patients had extremely high benefit in patients, whether they had nephropathy or not had nephropathy, in nephrological outcomes as well. And you had even heart failure outcomes that were reduced significantly. What about renal events? Poor my nephrologist friends, they don't even talk about it as their own domain when they have a molecule that acts through their action. They had reduction in these subgroup of patients in CANVAS with reduction in the heart failure and hospitalization. But if we look at the declared renal outcomes, again, huge amount of reduction, not only in improvement of eGFR and microalbuminuria, but even composite endpoint being reduced by 24%. Even decrease in GFR or renal deaths were reduced significantly, even the entire population. You look at the meta-analysis for heart failure and heart failure death, again, it extremely favors SGLT2. We all know that, but unlike MACE, this reduction is both in primary and secondary cohort outcomes. If you look at the SGLT2 trials of heart failure based on heart failure baseline characteristic, it's consistent, impressive. Heart failure benefits are observed both in patients who had heart failure or did not have heart failure. When we have AT2 receptor mechanism, when you have blood pressure reduction, when you have actions other than beyond just reduction in A1C, I think it's a far-fetched idea just to talk it and tout it as a molecule which is just a diabetic action. Nothing matters more than death, and CV death, to be specific. Whether you look at the EMPA-REG, CANVAS, or DECLARE, CV death and heart failure hospitalizations were all extremely favoring the SGLT2 class of molecules, whether you had multiple risk factors, whether you had diabetes, or even you did not have diabetes in DAPA-HF, or with heart failure or without heart failure, all actually favored CV death. So when you have a molecule which is talking about CV death, which is talking about blood pressure reduction, its mechanism of action, and my eminent friend Samit Ghoshal, his own papers, you look at him, I searched his name with PubMed, SGLT2 and Samit Ghoshal, and I can find 2 of his papers which are published, and one of them talks about heart failure hospitalization. Even his own forest plot, fantastic paper, I must congratulate Dr. Ghoshal, is again talking about Asian Indians, to be specific. And even in there, he talks about how CVOT outcome are important in these subgroup of patients. So when you have non-ASCVD, non-heart failure, non-nephropathy patients included, even then we do get CV benefits. Dr. Ghoshal's on paper in the executive summary, it talks about how they are beyond diabetes associated with blood pressure reduction, CV benefits, renal protective action. I wonder, is the diabetology only thing? And this is another evidence-based consensus paper, again, by Dr. A.K. Singh. Again, Dr. Ghoshal was co-author to it. And that also talks about treatment with SGLT2 reduces uric acid, reduces albuminuria. They might decrease diabetes complications, might decrease diabetic complications in patients with diabetes. So might decrease diabetes complication, but it does decrease CV death. Now you tell me, where does it lie? Reason 12. Shift of the guideline writings, even in cardiology. ACC guideline talks about it, where our cardiology guidelines are talking about giving an SGLT2 in guideline statements. Why does it not? What makes one thing that it should belong to maybe in diabetology only? So SGLT2 preferred in CV risk with metformin and lifestyle modification. And it also talks about consensus paper in heart failure. And it talks about CANA and DEPA should also be considered either established CVD or high-risk CVD on heart failure hospitalization. EMPA, of course, being considered at first. So it's a simple, the old story that I remember, an elephant, and then somebody came and caught hold of the elephant's trunk and said, oh, we have found a new snake. But unfortunately, when you look at the whole elephant, that was an SGLT2. So an SGLT2 is an elephant, and the cardiologist is the one who picked up that it's a elephant, not the spear, not a fan, not a snake, not a wall, not a rope, not a tree. It is an SGLT2, a cardiologist's domain. Thank you very much. Thank you for patient hearing. So you